Hello guys, can you see me? Am I audible? A very good evening guys. So how are you doing? How is your pathology residency? If I'm audible, just say me hi or hello so that I'll know that I'm able to talk properly and if the streaming is correct. Am I audible? Just a hi would help me. Okay. I hope I'm audible. Okay, so today what we are going to discuss is, I hope I'm audible, and today what we are going to discuss is, we are going to discuss about histiocytic lesions. Fine. Just a second, I'm just transferring the file. So when I say histiocytes are nothing but the other name of macrophages. Fine. So when I say anything about histiocytes, what I'm going to say is, I'm going to think about the problems which a macrophage is going to encounter, right? So this is a class of pathology postgraduates. I hope all of you here are postgraduates, and I would much appreciate if I have anything like if it's audible for you, do let me know. That will help me a lot for me to have feedback so that I can tune the class accordingly. If you're not audible also, just say at least a hi and say not audible so that it will help me to, again, I just want a response from you so that I know I'm on the right track. Okay, I suppose believe I'm audible. Fine. So we'll be going with benign histiocytic lesions. When I say benign histiocytic lesions, I just a second. Fine. Sorry. Is the chat open? Because I'm not able to listen to any of your chats or anything. Okay, so fine. I'm not going to take much time. I'm just going to start. If you have any doubts at any point of time, you are more than open to call. Right. So today we are going to talk about histiocytic proliferations. Of that, as the title says, we're going to talk about benign histiocytic lesions. So when I say histiocytes, which are nothing but macrophages. Macrophages have lots of disorders. Like I can have a tiny little bit macrophage proliferation as a result of infection, or I can have macrophage proliferation in many of the reticular endothelial system. I have benign lesions, and I'm sure you must have read about LCH, Langerhans histiocytosis, again histiocyte, right? So we are going to talk about histiocytic lesions. When I go to histiocytic lesions, when you're going to structure an theory question exam asking about histiocytic lesion, I want you to go with older classification as well as newer classification. One thing, because older classification always gives us an insight about the disease. Newer classification will help me to determine the prognosis and the subclassification of the disease, right? So when I go with histiocytic lesions, the older classification, what my older classification did was, it went into a non-neoplastic proliferation, a benign neoplastic proliferation, that's a second group, and also it went to an malignant neoplastic proliferation. Fine. These were the things which were in the previous one, an older classification of histiocytic lesions. In that, what we are going to discuss today is everything about my non-neoplastic proliferations, right? As you can see that these are the classification which comes under non-neoplastic classification of histiocytes. Fine. So when I say non-neoplastic classification, this is the most common thing I'm sure most of you must have seen in your pathology labs. If you are encountering MRM or a colectomy or gastrectomy, the lymph nodes which drains most of the cancers will have reactive sinus histiocytosis. That's the first thing we'll be seeing today. And then we'll go to second one, sinus histiocytosis with massive lymphadenopathy. Can anyone tell me there's one more name for this? Can anyone tell me the other name for sinus histiocytosis with massive lymphadenopathy? The other name for sinus histiocytosis is massive lymphadenopathy, that is a spotter. I'm sure you must have heard about a disease called as Rossoy-Dorfman. Right? I'm sure I must have heard, right? The other name of this disease is Rossoy-Dorfman disease. Fine. You must have seen spotters as well. If you have collection in your pathology lab, You will definitely must have seen case of Rosette-Hoffman, right? It's a spotter. It can come as an exam case as well, right? So it's good for us to learn a little bit about Rosette-Hoffman. If it comes in a 5-mark question, you should be able to write as well, right? Then I'll come to HLH. HLH again is an exam case in hematology, most likely in the bone marrow, not only in bone marrow. It's hemophagolymphohistiocytosis. Can be in any hematolymphoid organ. Most likely the image which will be given for you, the case which will be given for you will be bone marrow related, right? Then these are like a waste basket category. Again, it's non-neoplastic only. I can have storage disorder. Any storage disorder will have an histiocytic proliferation only, right? All these storage disorder, maybe just to fill the pages. I'm not going to discuss much about this because I'm sure that you can identify Niemann-Pick, Gaucher and Tangier with your clinical history. I don't want a biopsy to identify that. But on the other hand, all these three are important from my microscopic perspective. I can diagnose sinus histiocytosis in a microscope only. And it is a very, very important connotation. That's a very important differential diagnosis of metastasis of a lymph node. I'll tell you where you will fall down. We'll be mostly falling down during frozen section. I'll come to that soon, fine? So the first thing what you're going to see is reactive sinus histiocytosis. So to go ahead and read about reactive sinus histiocytosis, I want a preliminary understanding. I want you to know how good you know about the bone marrow. Right? That's a lymph node architecture first. When I take a lymph node, okay, at least I want answers for this, right? I am not gonna ask you anything if you say something wrong, okay? This is for PG residents, okay? It's okay. I'm not able to see the live chat here. Okay, sorry. This is for PG residents, not for anything. Fine, okay. So in a normal lymph node, what you will see? What are the groups you will see in a normal lymph node? In a normal lymph node, we are going to see about cortex and medulla, right? In a cortex, what I'll be seeing is you'll be seeing about your follicles, paracortical area and sinuses, right? In cortex, I'm going to see follicles, paracortical area and sinuses, right? Paracortex and sinuses. In medulla, my primary thing what I'll have only is in sinuses, okay? And I'm just repeating again this for residents, postgraduate students. It might not be much helpful for undergraduate. It will be a bit too much for undergraduate. If you're interested, you can definitely stay back, fine? So I need to know the difference between a cortical sinus and a medullary sinus. Because once I know the difference between a cortical and a medullary sinus, it will be very easy for me to understand and diagnose reactive histiocytosis, sinus histiocytosis, right? First thing is a reactive condition. See, what I have in sinus is nothing but an interrupted endothelium and basement membrane, which is there in almost every reticuloendothelial system, right? So in every sinus, what I will have is, you will have your histiocytes, or I'm going to call it an macrophage. Every sinus will have histiocytes, fine? So in other words, this is how a normal lymph node looks. This for understanding, this is normal. You can see the lymphoid tissue, predominantly composed of fat. You can see what is this structure. You can see a very thin pink color structure. That is your capsule, right? I can see the capsule. Here you can see the markings. It's written SFPF. PF stands for your primary follicle. SF stands for your secondary follicle, because there's a primary follicle, obviously, and this has a germinal center. This is a secondary follicle, right? And this is my paracortical area. Areas adjacent to the follicle. If you note carefully, I'm just going to draw in the first image itself. I'm going to draw a place. Can I say that this part here is a bit lighter in color? In between the two primary follicle, I have an area which is very, very light, right? Compared to the rest of the lymph node, which is completely blue in color, the green one which I have highlighted is very light. So which means, am I right in saying that this consists of a space where I have cells which has much bigger cytoplasm? Yes. So this is my cortical sinus. Okay. So this is the same image which is a little bit zoomed up, that's all. You can see a cortical sinus here. So in other words, in a low power, am I right in saying that cortical sinuses are very, very small? Yeah, this is a sinus. This is a low power again. This is a sinus. Okay, this is a sinus. All the cortical sinus in a low power, they are very, very small. Fine. So when you come to medullary sinus, the same lymph node, look at the third image. I'll mark this as 3, I'll mark this as 4. The third image, if you look at this, look at the medullary sinus. Again, this is scanner view. I can see the entire lymph node, it's a scanner view. Look at the size of the medullary sinus. And this is in a high power. The medullary sinus normally itself will be very, very enlarged. I want you to know this. Because when you look at sinus histiocytosis, don't look at a medullary sinus and say it is enlarged and call it sinus histiocytosis. That's not my problem. Normal scenario also, my medullary sinuses will be bigger only. That's normal finding, right? In other words, if the same big this person, if this appearance of the medullary sinus comes to my cortical sinuses, then I am worried, which means it is expanded. That's all, right? So it's a reactive condition where I'm having expansion of sinus histiocytes. So this is sinuses. I'll just compare the sinus here. Let's assume this is my lymph node. My lymph node, I'll have your afferent and my efferent vessels, right? From the medulla, my efferent goes. Let's assume like that, fine. So my sinus starts from here. It goes all over my cortex. In medulla, it becomes a little bit prominent and then it goes outside. It exits. Here it enters. So am I right in saying that if there is some person who's going to block this exit, will this sinus become bigger in size? There's a block in the exit. Is there a possibility the sinus becomes bigger in size? Yes, obviously. So when this medullary sinus becomes bigger in size, it's like a backflow, right? Normal backflow. Will the cortical sinus also become bigger in size? Yes, my cortical sinus also becomes bigger in size, fine. So that's a problem in reactive sinus histiocytosis. So in a reactive sinus histiocytosis, what happens is the exit is going to get blocked, right? It's normal reactive sinus histiocytosis, that's all. So where do I have an exit problem? Am I right in saying that when I have a tumor, a cancer, there will be desmoplasia surrounding the tumor? Can this desmoplasia go and obstruct my lymphatics? Possible, right? So let's assume this is the lymph node where I'm having an random tumor here, okay? And this tumor has spread out and is causing desmoplasia. So whatever this exit was there, maybe it could get blocked here by this desmoplasia. In other words, the place where I'm going to see reactive sinus histiocytosis are the places where it is adjacent to a malignant tumor. This is very, very important for a pathologist. It's not about diagnosing sinus histiocytosis. It is to rule out the differential diagnosis, fine? I'll tell you where you will fall down. You might fall down sometime. If you are careful, you can definitely swim through it, fine? So this is a normal finding seen in a draining lymph node of cancers, okay? So let's assume that how many of you evaluated frozen section? If there's any pathologist listening to it, just let me know how many of you have evaluated frozen sections or have seen frozen sections, reported with your consultants, any one of you. One of the important cause where frozen section is being done is for sentinel lymph node, right? So this becomes very, very important in my sentinel lymph node biopsy. So when I have a sentinel lymph node biopsy, my worry is this, okay? If you have evaluated frozen sections, you will know that the first place I will look for metastasis in a sentinel lymph node biopsy is the subcapsular sinus. If you don't know, I'm going to say this. You remember this always. Whenever you evaluate any sentinel lymph node, the golden rule is the lymph node should be complete. The capsule should be present, right? So when you evaluate a sentinel lymph node on a frozen section, which becomes it's bread and butter for almost every histopathologist, right? Let's assume this is the entire lymph node. The entire lymph node should be seen, and most importantly, the capsule also should be seen, right? You should have a section only with the capsule, because with the capsule is what is going to help me to identify the metastasis. A fluoride metastasis, first year PG also can identify. The difference between an experienced consultant versus a PG is I should not miss any case of metastasis. So even the tiniest metastasis, the first place where the metastasis comes is the metastatic foci is my subcapsular sinuses, okay? It's going to be in the subcapsular sinus. Once it goes to the subcapsular sinus, that's where I'm going to identify first. So I'm also right in saying that even metastasis in a metastatic lymph node, the sinuses will be enlarged, yes or no? When I'm having any metastatic lymph node, will the sinus be enlarged? Definitely the sinus will be enlarged, right? So here also my sinuses will be enlarged. If I'm having a match to a lymph node, here also there is a possibility that there will be an expanded sinus. Expanded sinus with Mets. I'll have metastasis there in the expanded sinus, right? So this is my problem here. When I have expanded sinus, can I have a confusion between a metastasis and a reactive sinus histiocytosis? Possible? Is it possible or not possible? It's definitely possible, right? This is going to be my predominant confusion whenever you are evaluating your frozen section. Because in frozen section, I will not be able to appreciate the morphology much. It's not like my paraffin normal H&E section, right? It's not so good, okay? Okay, Rishabh, this is not an IAS preparation channel. This is for NEET PG. It's for doctors. Okay, fine. Thank you for visiting still. Okay, so I'll have this difference here. Fine. When I have this difference, how I'm going to differentiate is, if you're looking at a frozen section, okay, I want you to look at only one finding, any metastatic foci, any cancer. Am I right in saying that every tumor cell will have a high NC ratio? Yes. So any metastasis will have a higher NC ratio. You will have a high NC ratio. The NC ratio will be very, very big. That's a hallmark of any malignancies, right? NC ratio is going to be big. On the other hand, when you looked at the sinus, this is where we looked at the sinus, right? This is where we first saw the sinus. I told that the lymph node and the sinus, which was lighter, the sinus was lighter. In other words, sinus has macrophages, which has very huge amount of cytoplasm, which makes it look lighter, right? So in frozen section, what you're going to do, METs versus a sinus macrophage. I need to differentiate them. The easiest difference between METs versus sinus macrophage is your low NC ratio. Or in other words, almost every macrophage in the sinus will have an increased amount of eosinophilic cytoplasm. It will have a pink color cytoplasm. That's the hallmark of a macrophage, any macrophage, right? So that difference I want you to understand. So next time, I'm sure daily you will see at least one case of an MRM or whatever it is, any surgery, where you'll isolate lymph nodes. I want you to concentrate tomorrow, okay? Hi Lakshmi, I want you to concentrate tomorrow, look at the lymph node, microscopy, appreciate a sinus macrophage and the high NC ratio. This can be useful in a post frozen section, normal routine histopathology as well, right? So in other words, to call it sinus histiocytosis, all my sinuses should be expanded, not just medullary sinus, right? Look at this. This is the second image. In this image, what structure is this? Though it is in the corner, what structure is that? Am I right in saying that it's pink in color? Pink in color, most likely your capsule. See, this is a lymph node biopsy only. So I have a capsule in the corner. What is this? Definitely a secondary follicle. You can see a germinal center, you can see a secondary follicle. So this is capsule. So am I right in saying that whatever I'm seeing here are cortical sinuses? Yes. I'll just compare the normal cortical sinuses. So this is the size of my normal cortical sinus. This person. So am I right in saying that the cortical sinus in the image 2 is definitely bigger than the cortical sinus in the first image? Definitely is bigger, right? So in other words, I'm right in saying that these sinuses are dilated. Okay, these are dilated sinuses. That's the only information I'm going to get from this. These are dilated sinuses. Whenever I have dilated sinuses, as we know, I have metastasis as a possibility, or I have your reactive sinus histiocytosis as the second possibility. I need to rule it out. So what do? You go for a higher power. Again, I'm warning you, every diagnosis a pathologist is going to make should be made either on 10x, 20x, 40x just to confirm the diagnosis. Most of the time, don't go for 40x. We will tend to overdiagnose when you go for a 40x, right? So this, I know that it's a dilated sinus. When I have an information of dilated sinus, next I'm going to go zoom it a little bit. This is a little bit higher power. Am I right in saying that? Let's just concentrate on this cell alone, or maybe this cell. Am I right in saying that whatever cell I am highlighting, the amount of cytoplasm is definitely more? Yes, there's definitely good amount of cytoplasm. Maybe if you want, I'll zoom it. Take any cell. Take any cell. Definitely the amount of cytoplasm is more, right? I do have lots of cytoplasm here. So it's not a malignancy. So I'm going to sign it out as reactive. I want you to commit, right? Don't just say it's a sinusoidal proliferation with histiocytes. Please commit. Reactive sinus histiocytosis. Okay. I want to commit on this because the biggest complaint which is given for pathologists is we always write correlate clinically, right? We'll put a stop to that. Commit whatever you are seeing. Don't be hesitant about it. You know the subject, you are going to commit it, right? Write reactive sinus histiocytosis. Don't write reactive lymphadenopathy. Give it a perfect name. I want you to try to give a perfect name for everything. Only then I will be able to go for a difficult diagnosis. This is a very easy diagnosis. Here I should not be cat on the wall. On perfect, on target, fine. Okay. So we know about reactive sinus histiocytosis. I want you to lead to the second disorder here. I'll just go back to the classification, whatever we saw. This was the classification, right? We had reactive sinus histiocytosis. Then we have sinus histiocytosis with massive lymphadenopathy. I call them Rosai-Dorfman disease. Okay. How many of you have seen slides of Rosard Hoffman, or have you heard about Rosard Hoffman? Varun, in relation with malignant histiocytosis, yes, I can have sinus histiocytosis also. We'll have the next session on malignant histiocytic proliferation. There definitely I'll discuss about malignant histiocytosis. The pleomorphism is going to give me the way, and histiocytosis, when it's malignant, you'll have a background, more of the background, which will help me easily in the diagnosis. We'll definitely compare that, right? Perfect. You'll see emperipolysis, right? That's one of the important finding in my Rosard Hoffman disease. Okay. Now I'll just go to the image what I showed last. Am I right in saying that this is not my case? It's from internet. I'll show you my case as well. Am I right in saying that these guys have emperipolysis? The cytoplasm has tiny cells. Yes, no, right? You can definitely see emperipolysis here, right? So I'm kind of linking my sinus histiocytosis with the second finding. The second finding is it could also be Rosard Hoffman. I do have differences between sinus histiocytosis and Rosard Hoffman also. We'll see them also at the end of Rosard Hoffman. Fine. Next, what you're going to go to is sinus histiocytosis with massive lymphadenopathy. The other name is Rosard Hoffman disease. Fine. That's what we're going to see next. So Rosard Hoffman, many of you said that you've seen case of Rosard Hoffman. If I may know, which structure have you seen? Is it always in a lymph node, or it can be anywhere? It's always in a lymph node, or it can be extranodal Rosard Hoffman as well. It can be extranodal Rosard Hoffman as well, right? I can see Rosard Hoffman in lymph node as well as I can see in extranodal. First, we'll have an overlook of the patient profile. I need to know about the patient profile. Yes, I can have Rosard Hoffman anywhere. When I come to patient profile, if it is lymph node Rosard Hoffman, we do have lots of extranodal cases. You can have it in Sinus, you can have it anywhere in the body, GIT, skin, anywhere in the body. Fine. Most of the nodal case of Rosard Hoffman happens in young adults, right? Yes, nasal is also possible. Anywhere in the body it's possible. Fine. It's a very massive lymphadenopathy. You will have constitutional symptoms. Fever will be there, weight loss will be there. Because when I say emperipolysis is happening, or something is going inside the macrophage, or macrophage is trying to eat it, definitely inflammation cascade is going to be activated, right? It will be young adult, most of the times cervical lymphadenopathy. It can be anything, as I said. You'll have fever and a little bit of weight loss. Okay, if a proper history is evaluated, both nodal as well as extranodal Rosard Hoffman will have a predisposing viral infection. There will be a preceding viral infection. These points you can write for a theory exam. For a diagnosis, these are not required, but yes, I see certain findings. I'm going to call it Rosard Hoffman irrespective of the history. But for theory exam, you need to fill up sheets, right? There'll be a preceding viral infection. Okay. That will be there in most of the cases. If not there, fine. It's just an asymptomatic thing which we have missed. So when I come to the etiology of Rosard Hoffman disease, okay, when I come to etiology of Rosard Hoffman disease, as I said, that can be a predisposing viral infection. So I'm going to link one virus, which I'll link for almost every case of lymphoma and lymphadenitis. What virus will be there? That will be the first common virus here as well. Fine. So when I come to the pathogenesis, first thing, I'm not so sure about the pathogenesis. There are two schools of thought. The second school of thought has come recently. We are trying to push Rosard Hoffman also into a group of IgG4 related disorder. Not an IgG4 exactly. I'll tell why not IgG4 exactly. Right? Most of the Rosard Hoffman can have herpes group of family infections. EBV. Right? EBV is common for almost every lymphoid problem. Right? Herpes group, EBV can be polyoma, can be parvovirus, can be any autoimmune disorders like SLE as well. Right? Can be SLE. I'm writing AA for autoimmune diseases. I can have, in all these conditions, I can have Rosard Hoffman disease. Possible. Just a massive lymphadenopathy. I don't know what exactly is happening, but my macrophage is getting proliferated, a benign non-neoplastic proliferation, and is trying to eat up everything. Right? So the second thing is, there is a slight inclination towards, I'm putting a query, IgG4 mediated disease. I'm thinking whether Rosard Hoffman is an IgG4 mediated disease also. The simple reason is, someone said, Meenakshi said that she saw a nasal case of Rosard Hoffman disease, right? In a case of a nasal Rosard Hoffman, am I right in saying that in nose, I will not have sinuses? I won't have sinuses, right? Only in hematolymphoid reticuloendothelial system, I'll have sinuses. Skin, I won't have sinus. CNS, I won't have sinus. When I don't have sinus, I cannot call it sinus histiocytosis. It's an accumulation of macrophages. In most of the case of extranodal rosette Hoffmann disease, I'll have accumulation of macrophages, and surrounding them I see lots of lymphocytes and plasma cells. And those plasma cells were positive for IgG4, right? It has an inclination towards IgG4 mediated disorder for the only reason I do have, especially in extranodal disease, I do have a slight inclination that majority of the extranodal rosette Hoffmann will have IgG4 positivity on microscopy. When I do an IHC, it will be positive. But why I did put the mark query is, whenever I say IgG4 mediated disorder, there is a set criteria, right? Can you, any one of you tell what are the criteria for an IgG4 mediated disorder? At least one or two. There are set microscopic criteria. We need to have one classical type of fibrosis. We need to have storiform fibrosis. I'm sure you must have heard about that. We need to have a dense lymphoplasmatic infiltration. We need to have phlebitis. Not just pancreatic, anywhere I can have fibrosis, right? I need a very set microscopic finding. I don't see the storiform fibrosis in rosette Hoffmann. I do see IgG4. I don't see phlebitis in rosette Hoffmann. And most importantly, serum levels of IgG4 also should be elevated. It should be actually greater than 135 milligram per deciliter, right? All these are characteristic of a rosette of an IgG4 mediated disorder. I don't see any one of them in rosette Hoffmann extranodal. The only finding I see is IgG4. So what they have said is, can an autoimmune disorder, any autoimmune disorder, will there be increase in the amount of immunoglobulin produced? Yes. Can that immunoglobulin have expression of IgG4? Possible, right? So they found that there's an incidental finding. That's all. I'll tell you, Avinash. Okay, it's an incidental finding. You can easily differentiate an emperipolysis from a giant cell. Okay, I'll definitely tell you. Fine. So look at this. This is what my pathogens of rosette Hoffmann goes away. So when I'm going to go with microscopy, I have three different cases. One I have taken from internet. Two of them are my routine cases, right? I'll tell you how to work up those cases. Okay. So first thing, I want a preliminary understanding about you. Tell me how an histiocyte looks. Because if we know how an histiocyte looks, all these histiocytic disorders are very, very simple. They are definitely larger cells, right? Undoubtedly, they are larger cells. Second, the cytoplasm will be pink or blue or clear of a histiocyte. Third is main nucleus. Cytoplasm will generally be pink in color, right? It will generally be a huge pink color cytoplasm. When I come to the nucleus of an histiocyte, a histiocyte, is it functional or not functional? Is it functional or not functional? Histiocytes. Come on, if you say wrong also, it's completely fine, but I want answers. I'm not going to remember any one of you. It's a session for us, both of us, to improve mutually. A histiocyte is a functional cell, right? Only since it is functional, I'm having a pink color cytoplasm. When a cell is functional, Avinash, this is especially for you since you asked that doubt. When a cell is functional, the nucleus should be active or inactive. The nucleus should be active, right? When I have an active nucleus, am I right in saying that it should be open? It should have open chromatin? Yes. Every active nucleus should have an open chromatin, right? So when I come to the nucleus, okay, when I come to the nucleus, you'll have an open chromatin. Okay. Fine. Okay, I'll come to query as well as well. I'll have an open chromatin. I'm going to go with the nuclear chromatin, that's all. I will show you emperipolysis. You'll have a normal histiocyte will have an open chromatin, right? Is this emperipolysis? This is an image from web pathology. This is not my case. Is this emperipolysis? Are you convinced this is emperipolysis? Yes, this is definitely an emperipolysis. Got it? We'll just look at this cell. Here I have 5 nucleus, right? In this cell I have 5 nucleus. In this, these 4, they are outside cell nucleus. They are heterochromatin, very dark. Am I right in saying that this nucleus is a euchromatin? It's a functional nucleus. When I have a giant cell, every nucleus will appear the same because all of them are histiocytes nucleus. It is not coming from outside. That's a main difference. Got it, Avinash? An emperipolysis is something coming from outside, most likely lymphocytes or RBC. RBC you can easily pick it up, right? Hemophagocytosis. Most likely when you have a lymphocyte or a plasma cell, the nucleus gives me the way. If it's a giant cell, every nucleus will be like this. This is an histiocytic nucleus. This is an histiocytic nucleus. All these are, whatever I'm ticking, are histiocytic nuclei, right? I can easily differentiate a histiocytic nucleus from an emperipolysis cell, right? That you keep seeing cases, you will definitely able to pick it up. It's not a difficulty at all, fine? So this is how an emperipolysis looks in a rosette of man. So we need to know normal, that's all. If you know normal, abnormalities is a piece of cake, okay? I'll come to extranodal. As I said that, my problem in extranodal is there are no sinuses. There are no sinuses in extranodal, fine. Second thing, when I don't have sinuses, I will not have a space like this. Whenever I had lymph node sinuses, it will be in an enclosed space. Here I won't have a space. So it's just a collection. Welcome Avinash. Collection of macrophages. Collection of macrophages in the background of normal lung, if it is in lung, CNS, whatever organ it is. It's a collection of macrophages. So it will be very irregular. I won't have an endothelial lining. I won't have anything. It's just a collection of macrophages. So when I say a collection of macrophages, as I said that, I need you to pick up everything on a low power. On a low power, tell me, it's a collection of histiocytes or macrophages. Macrophage, I meant histiocyte. They'll be dark or light. That's one thing I want you to understand. It's a collection of macrophages, so they are definitely going to be extremely light. It's going to be extremely light in appearance, right? So a faded pink color, that's what I meant as light, not the blue one. In any place, a collection, I'm going to say that, okay, this is an histiocyte. I have many differential diagnoses. We'll come to the differential diagnosis soon, fine? Third, you will have background very loose fibrosis. Okay, the background loose fibrosis. Rosette of man in extranodal is difficult to identify. Meenakshi said that she saw nasal case of rosette of man. In nose, do you think that emperipolysis is common or rare? See, in a lymph node, in a spleen, in liver, I have hematolymphoid tissue in excess. Emperipolysis is very, very easy. Lymph node, definitely easy. But in extranodal tissue, one of the important thing is emperipolysis is rare. I'm not saying it's absent, it's rare. So which means you have to search. You need to have a little bit of patience. Fine. Emperipolysis in extranodal tissue will be rare. I'm having a collection of macrophages. That's my important finding. Then I zoom it up in. It's going to be, you can see emperipolysis, right? You will have loose fibrosis in the background, right? This is our case where you can see that fibrosis. You can see these are all collection of histiocytes. All of them are collection of histiocytes. Am I right in saying that when you look at this image, there's definitely a little bit amount of fibrosis in the image in the background? Yes, you do see a very hazy fibrosis, right? Fine. You do have a very hazy fibrosis, like sweeping fascicles of cells. That is very important in my extranodal. I do have collections of pink color cells. I presume it is histiocytes, and I'll go to zoom it up. One thing I will see in excess is what are these collection of cells which we discussed in our theory itself. What are these collection of cells? This is my histiocyte. Okay, this is an histiocyte. I'm just covering histiocytes, and this collection of cells. What cells are they? Welcome, dog god. What collections of cells are they? Maybe I'll zoom it a little bit. I'm sure you can appreciate it much better here. These are group of plasma cells, right? It's a group of plasma cells. I'll have more amount of plasma cells in the background. That's why I said that it's confusing with an IgG4 mediated disorder, right? I can see emperipolysis. Am I right in saying that in this image itself, can I say this cell has phagocytosis? If you want a little bit zoom it bit more, there's RBC inside that, right? There's RBC inside there. You can see the glistening one. So I do have phagocytosis. Emperipolysis might be a little bit rarer, but background collection of plasma cells and lots of collection of histiocytes and a loose fibrotic background will give me a clue of rosette of man. I am not confirming it is rosette of man because extranodal rosette of man is a bit difficult. It's a bit difficult to identify, especially when it comes to skin. Whenever it's extranodal, automatically you have to have many differential diagnoses. You start ruling out one by one. Fine. Next one is this skin. See, this is also our case. Look at the skin biopsy. You must have seen normal case of skin biopsy, right? How many of your colleges have routine skin biopsies? Skin biopsies. How many of you have routine skin biopsies? Not much. So if you have seen a skin biopsy routinely, Am I right in saying that this dermis is extremely light? It's a scanner view, obviously. There's an extremely light dermis. Dermis will generally be a bit more pink, right? It's full of collagen, it's going to be more pink. This again is an extremely light dermis. Again, the diagnosis and the differential diagnosis should be always picked up on a scanner view, on a low power view. In a scanner view, I do see the epidermis. When you look at the dermis, it's extremely light here, right? Perfect, right? The extremely light dermis. I'm not seeing any hair follicles, no adnexal structure. In low power, I can pick up these adnexal structure, right? An extremely light dermis. So I have many differential diagnoses. Let me go to a higher power view. Same case, when you look at the higher power view, look at these. Are all these histiocytes? All of them, right? All of them here are histiocytes. I have lots of histiocytes. Entire dermis is filled with histiocytes, right? So this is what I said. I don't have sinuses. I have lots of histiocytic collection. Okay. I'm going to ask you the differential diagnosis here now. In dermis of a skin biopsy, I'm having n amount, so many histiocytes. What should be a first differential diagnosis? Perfect, Minashi. I have to think of leprosy. I see so many histiocytes in a skin biopsy. My first possibility is leprosy, not Rosai Hoffman, or maybe tuberculosis, not Rosai Hoffman. Infection is much more common than Rosai Hoffman. So am I right in saying that I have to do an AFB here? You have to. Should I do an AFB? Yes, I have to do. Fight for a co? Yes, I have to do. I have to rule out all differential diagnosis, right? So in extranodal, with rarity of your emperipolysis, all the differential diagnosis should be ruled out, right? I do have to rule out the differential diagnosis. So before giving a diagnosis of Rosai Hoffman, I need to rule out all these conditions, right? So in other words, what are my differential diagnosis of Rosai Hoffman? We know how to identify Rosai Hoffman in a lymph node, collection of histiocytes in your sinuses with classical emperipolysis. Extranodal, loose fibrosis, aggregates of macrophages, emperipolysis will be there, but bit difficult, and your lymphoplasmacytic infiltrates, right? So differential diagnosis, my first differential diagnosis, it's a histiocytic proliferation. Am I right in saying that LCH can also be a differential diagnosis? Yes. My first differential diagnosis here is Langerhans cell histiocytosis. Second, in skin or in lung, tuberculosis can be a differential diagnosis, right? Leprosy, tuberculosis. Again, in skin, can xanthoma be a differential diagnosis? Yes. Xanthomas, xanthelismas, right? It can definitely be differential diagnosis, because in skin those are definitely possible, right? I need to consider all of them, because when I'm going to sign it out as Rosai Hoffman disease, most of them are self-limiting, spontaneous remission, but LCH is not spontaneous remission. I need to keep that in mind. Whatever you're going to sign out, you're going to have an implication in the patient's management, right? So these are my possible differential diagnosis. Other one, like Varun said, that is a malignant infiltrate possible, still possible, right? A malignant histiocytosis is also possible, right? There are groups of malignant histiocytosis. We'll see them in subsequent classes, fine? So these are my possible differential diagnoses. So I have to rule out them, okay? So when I'm going to rule out any time, keep this in mind forever in your entire practice as a pathologist. You need not save on IHCs, right? I'm sure when you are being taught in your college, what you have been told is morphology is the gold standard, right? How many of your professors hate immunohistochemistry? Most of them used to say, on morphology, tell me differential diagnosis. On morphology, tell me differential diagnosis. That's how you must have been trained, right? Morphology is ultimately important. But when I come outside, I have many things in stake. Please do an IHC. Why I'm telling do an IHC is, I'm saying something is not as emperipolysis. Can another pathologist call it an emperipolysis? Definitely. But when I'm saying, okay, this lesion is CD1A negative, that will be negative for every pathologist. It's objective. Morphology is a subjective finding. Always go for an objective finding, right? So my first differential diagnosis here is LCH. I'll tell you the difference between microscopy as well as I need IHC as well. So LCH microscopy, the first clue is the Langerhans cells. It's a neoplastic proliferation, right? The nucleus totally changes here. You'll have the grooving in the nucleus. That's very common, okay, in LCH. the grooved nucleus, the coffee bean appearance, if I may say. Fine. Second, LCH in background, will they have plasma cells or they will have eosinophils? The background LCH will have eosinophils in the background. Generally eosinophils in the background, right? So a background eosinophils with a grooved nucleate, LCH also will not have pleomorphism. LCH is mostly like a benign proliferation only. They also will not have pleomorphism, right? So I cannot go with nuclear characteristic for this too, right? Emperipolis will be absent. I didn't say emperipolis for the one reason. Sometimes it might be difficult in a skin biopsy, even in Rosard Hoffman, to evaluate emperipolis, right? But yes, for sure, theoretically, no emperipolis. So when I come to immunohistochemistry, let's make it like this. Our LCH, I'll write RDD for Rosard Hoffman disease, fine. So in Rosard Hoffman, am I right in say, we'll come to Avinash, we'll come with each differential diagnosis separately. In Rosard Hoffman disease, am I right in say that those histiocytes will be S100 positive? Will they be S100 positive? Because they are also histiocytes, dendritic cell histiocytes, right? They will be S100 positive, especially in the skin, definitely positive. So that will not help me here. Both Rosard Hoffman as well as my LCH will be S100 positive. Both of them will be your monocyte macrophage markers positive, fine. Manpreet, I didn't go with sinusoidal dilatation for the only reason, extranodal. I might not have sinuses always, right? So both will be CD68 positive. I think this will be the most common marker what you'll have for monocytic lineage, macrophage lineage in your college. 14, 64, 68, all of them will be positive. My thing here is, if I have to prove it is LCH, I'm going to go for CD1A. Okay, CD1A will be positive in LCH. Here CD1A will be negative in Rosard Hoffman. There are few cases of Rosard Hoffman which can be CD1A positive, but even then it will be very patchy positivity. So I need this and this both in synchrony for me to differentiate this from Rosard Hoffman, because I need this to differentiate. Langer and Avinash, it's more theoretical. Practical CD207 is a bit difficult to get it unless you are in a very superb setup. But CD1A is a kind of a medium range marker which will be available everywhere, right? So I want you to go with a practical application as well, because when you go and work in a hospital, you ask for Langerin, they might not have Langerin. So I should not be stuck there. So 1A is a minimal requirement for me. So I'll go with 1A, fine. I'm going to bring in the economics of pathology as well, because whatever you read, you go outside, you might not have everything. We have to diagnose with the limited resources, fine. Okay, these are my differential diagnosis. The reason why I have to have a differential diagnosis between these two is, okay, CD68 will be positive for both. That will not help me to the differential diagnosis. Only thing which will help me for differential diagnosis, CD1A positivity. If you have alpha-1 antitrypsin, chymotrypsin, those will be positive in my Rosard Hoffman. I'm not going into it because they are rare markers available in the lab, fine. Okay, so the reason to differentiate is LCH, a few variants might need chemotherapy. Okay, might need chemotherapy, few variants. But most of the cases of Rosard Hoffman, I'm not saying all of them, are self-limiting. Most of the lymphadenopathy in Rosard Hoffman will come back to normal within 6 months. I really don't know what's happening, and the long-term survival also very good. So I need to differentiate, I need to give a diagnosis. Whenever you are hesitant, please apply immunohistochemistry marker. Don't be laxed on that at all, fine? That's my first thing. Next we'll come to leprosy and tuberculosis. See, leprosy and tuberculosis are very simple to identify. One, I can do a Phyte Ferraco and an AFB. You need extremely superb patient to look at Phyte Ferraco and AFB. But this variant of leprosy or maybe tuberculosis, am I right in saying that if it is leprosy, Phyte Ferraco will be definitely more positive here because it's huge macrophages, right? You might have globi, lots of them will be positive. So especially here, it will be very easy for me. For leprosy and tuberculosis, I am going to apply your special stain. I don't have IHC for this special stain, Phyte Ferraco or your acid fast basal. Fortunately enough, if I have such a huge collection of histiocytes in a skin biopsy, this Phyte Ferraco will definitely be positive. It will be easily picked up for me. I'm just going to have a difference of opinion here. Let me know what comes to your mind. Can I have a fungal infection of skin like sporotrichosis or anything with so much of histiocyte? Possible. Can I have a fungal infection in skin with lots of histiocytic response? Possible. Generally possible, right? So it's not only leprosy TB. I'll just add one more person, fungal infections as well. So please add GMS also, right? That's also possible. So all these should come in differential diagnosis. When I say an infection, can I also say that invariably let it be tuberculosis or leprosy or fungal infections? Giant cells are possible. Histoplasma as well, right? So I'm going to go with stain. If I want to extrapolate in terms of my microscopic appearance, giant cells can give me a clue. Again, I'm favoring more infection related. If I have granuloma, well and good. I'm favoring more infection related because granuloma will not be seen in Rosette Hoffman. Right? Giant cells also unlikely in Rosette Hoffman. Like Avinash asked, you should be able to differentiate emperipolis from giant cells. I'm sure you will do that for sure. Fine. I need to be differentiating that. Fine. Xanthoma, xanthelisma, clinical history is the clue here. I need to pick up from clinical history. If you will have a requisition form saying it's xanthoma, even if not, if you're seeing case of xanthoma, they are very, very classical. It will have foamy histiocytes. The histiocytes will have lipid inside them, fine. So xanthoma, again, I'm going to go with microscopy. You will have both histiocytes as well as giant cells in xanthomas as well. But here, you'll have a very, very foamy cytoplasm. Okay, foamy cytoplasm in the sense you are going to have lipid inside them because they are lipid-laden cells, right? So that will help me to differentiate. Morphology is easily, and clinical finding, no one is going to confuse xanthoma from Rosette Hoffman disease, fine? And malignant histiocytosis. We'll see them when we come to malignant histiocytosis in detail, but here, as of now, I'm saying that atypia. Atypia is the characteristic finding here, fine? Atypia is definitely the characteristic finding, that helps me, okay? Just one possibility, I didn't write it here. See, these are my differential diagnosis. Whenever you read any textbook, I want you to concentrate more on differential diagnosis rather than the pathogenesis. See, pathogenesis is for a student, for understanding. You understand the disease, that's enough. But when you're going to come and sit in a consultant's place, the only thing what you want is this. I need to identify them, fine? I'll come to HLH, Avinash. I need to identify these things. Only when I know these are the differential diagnosis, I will look for that. Otherwise, I'll not look for that. If you don't look for that, there's a chance of missing. Any textbook in pathology if you're reading, concentrate and spend more time on differential diagnosis, fine? Next, is there a possibility my reactive sinus histiocytosis can be mistaken for an Rosette Hoffman disease? The first thing we saw, a reactive sinus histiocytosis, possible? Definitely possible, right? So that also is my differential diagnosis. I'll come, ignore this for now. I'll come next. We'll go to HLH. Fine. Next possibility is I can have an reactive sinus histiocytosis as an DD for Rosette Hoffman disease. Okay. Reactive sinus histiocytosis is due to blockage. The exit is blocked, so it's getting accumulated. Rosette Hoffman is in proliferation of histiocytes. So which of these two do you think will cause more expansion of histiocytes or the sinuses? Obviously Rosette Hoffman, right? Here there will be lesser expansion of sinuses. Okay. Here there will be much more expansion of sinuses. Okay. Have a much more expansion of sinuses here. When I say much more expansion of sinuses in a lymph node, I'm not talking about your non-lymphoid organs here. If sinuses becomes huge, am I right in saying that in Rosette Hoffman disease, it will destroy the surrounding normal lymphoid parenchyma? Yes, right? Here there will be, if it is Rosette Hoffman and lymph node, there will be no normal lymphoid parenchyma. Okay, there will be no normal lymphoid parenchyma. In other words, it's like a diffuse effacement. It's a diffuse effacement of small lymphoid cells, that's all, of my histiocytes, that's all, fine. Here, I'll just go to the first image what we saw. Even though it is reactive, it's expanding everything. Look at this. I can still see my normal lymphoid parenchyma. Here also I can still see my normal lymphoid parenchyma. In a reactive sinus histiocytosis, my normal lymphoid parenchyma will undoubtedly be seen. Right here you will see the background parenchyma will be present. Okay. You'll have the background parenchyma for sure in a case of reactive histiocytosis. And obviously the one thing which is going to help me is my emperipolis. Though that's secondary, emperipolis will help me. and history of an lymph node of axillary node in a suspected breast cancer, draining lymph node of a cancer, that will be favoring more towards an reactive sinus histiocytosis. Fine. Okay. Any doubts in Rosard-Hoffman? Will you be able to pick up any case of Rosard-Hoffman in future? Yes. Hopefully. Okay, great. So that's about our Rosard-Hoffman disease. Fine. So one more non-neoplastic proliferation of histiocytes is my HLH, hemophagolymphohistiocytic syndrome. It's a huge group. Fine. Maybe we'll see half of it today, and maybe we'll do the rest of the half of hemophagolymphohistiocytic syndrome in the next class along with your malignant histiocytosis. Fine. Great. Okay. Super. So next, what we're going to read is about HLH. Okay. So in hemophagolymphohistiocytic syndrome, this is also a non-neoplastic proliferation. How many of you have seen case of HLH? It's a spotter for you. It's an exam case for you. Okay. How many of you seen case of HLH? Anyone? I'm sure you must have seen. No? You must have seen, right? HLH is an exam case. I want you to read. So one difference between HLH and Rosard-Hoffman. Which of these two will have cytopenias? HLH or Rosard-Hoffman? Cytopenia, fever, splenomegaly, constitutional symptoms. Which will have more? Rosard-Hoffman or HLH? HLH. The clue here is clinical history. Clinical deterioration. Okay. Fine. Okay, Manpreet, you'll see. You have to be very careful while diagnosing HLH. Right? Clinical deterioration is a clue. HLH has a very set criteria. You have pancytopenias, you have ferritin levels elevated, triglyceride levels elevated. It's like a DAC, low grade DAC, fibrinogen. There's a very set criteria. Fine. At the same time, keep this in mind always. HLH will have hemophagolymphohistiocytosis. Right? Hemophagocytosis. Can you differentiate on a microscopy hemophagocytosis versus emperipolis? Is that possible to differentiate or not? On a microscopy, nothing else. Hemophagocytosis versus emperipolis. Can I differentiate? The answer is no. Right? No one on earth can say that this is hemophagocytosis, this is emperipolis. No one can say. In other words, even a normal bone marrow, I'm sure you must have seen bone marrow aspirate. A normal bone marrow aspirate can also have emperipolis. Emperipolis is normal phenomenon in bone marrow, right? It's not always abnormal, which means if you see emperipolis in a bone marrow without a clinical history, it is not HLH. It is not HLH, right? So don't overdiagnose also. That's very, very important. This hemophagocytosis or an emperipolis, first possibility can be normal. Every normal bone marrow, next time when you get a bone marrow aspirate, I want you to spend time maybe 10-15 minutes extra and look for the macrophages. If you see for macrophages, definitely if you look for some 10-20 macrophages, one of them will have phagocytosis. That is normal. It can be completely normal. Fine. Definitely can be completely normal. Second, can I have an HLH without hemophagocytosis? That is also possible. Fine. When I say hemophagolymphohistiocytic syndrome, it's possible to have, can be without hemophagocytosis. Okay, can be without hemophagocytosis, which means I don't want hemophagocytosis to call it an HLH. I have other criteria. I have 5 out of 8 criteria. If 5 of them are positive, I can easily call it HLH and I'm going to go with the treatment, right? So both extent are possible. I can see hemophagocytosis normally. At the same time, a full-blown case of HLH may not have hemophagocytosis, which means I'm not seeing at the time of pathogenesis. That's all. Doesn't mean that I missed it. Maybe in the aspirate it does not come. Maybe in the biopsy it does not come. Fine. So when I come to HLH, we have 2 groups of HLH. This is more for theoretical question answering. Primary HLH and your secondary HLH. Fine. So primary versus secondary HLH. It's again, as I said, it's more a theoretical question because HLH can come as a short answer as well. You should be able to differentiate a little bit out of it at least. Right? When I say primary, not only for HLH, any disease, when I say primary, what could be the most possible etiology? I'm not asking the only etiology. There's definitely one possible etiology will be there, right? Generally, anything primary should be idiopathic or genetic, right? That's what we generally give. Primary also is called as a familial HLH. Fine. Primary or a familial HLH. Generally, it's going to be genetic or your genetic condition or familial condition. Most of the HLH are autosomal recessive. When I say autosomal recessive disorder, almost every autosomal recessive disorder will present during infancy. Fine. The difference between primary and secondary HLH, it's during infancy. Okay. Here it's adults. Most of them are autosomal recessive inheritance. I'm writing AR for autosomal recessive. Your infancy and adults. Fine. When I have a primary HLH, it should not be associated with any other disorder. Like I should not have an immunodeficient patient. I should not have malignancy. If you want to prove and diagnose as primary HLH, malignancy should not be there. Immunodeficiency should not be there. No background disease should be there. Right? The disease is primarily due to the mutation, nothing else. Right? There should be no immunodeficiency. There should be no malignancy. Right? Which means secondary HLH can be secondary to any infection, malignancy, GVHD, immunodeficiency, anything. Right? Here I'm writing ID for immunodeficiency, could be a cause. Malignancy could be a cause. Right? GVHD could be a cause. Fine. Or maybe your any infections can be a cause. Here, as I said, the cause is mutations. I'll just give you a hint of what mutation is just to make your answer a little bit bigger. Most of the mutations of primary HLH is going to affect my natural killer cell function. Fine. Most of the mutation affects NK cells cytotoxic function. NK cell or your CD8 cell cytotoxicity. So we'll go back to an undergraduate question. The CD8 T lymphocytes. What do you think are the effector molecules? If I take a CD8 T lymphocyte, what will be the effector molecules? Like CD8 T lymphocyte or an NK cell, cytotoxicity will be based on this release. What release? They'll release two components, perforin and granzyme, right? In other words, most of the primary HLH are interfering with perforin mutations. You must have read about perforin and granzyme. So that perforin is a problem. So my NK cell cytotoxicity is not happening. Because of that, my CD4 and my macrophage overfunction compensates and eats everything and destroys it up. That's a primary problem in my HLH, right? Here it is not that. It is not mutation. Here is due to some other secondary problem. Fine. Primary HLH, it's a progressive disease. Prognosis is difficult. Here, I will not call it self-limiting. If I have a patient with HLH due to Hodgkin's lymphoma, just a scenario, I treat Hodgkin's lymphoma, HLH automatically will reverse. HLH due to HIV, I make sure CD4 count elevates, HLH will automatically reverse, right? Here, it's possible to have a remission if the underlying cause is treated. If the cause is treated, it's possible to have an outcome, right? The outcome might be a bit better. Family history will be there in primary HLH, family history will not be there in secondary HLH. Microscopy wise, no difference. That's a good thing here, or maybe the bad thing here. Microscopy, both will be the same. What I'm going to have is hemophagocytosis or emperipolysis, whatever you want to call. In HLH, I'm going to use the term hemophagocytosis. That's all. I'm going to eat RBC, any WBC, even a megakaryocyte. Macrophage can go and eat a megakaryocyte. Such a huge set, but still it can be swallowed up. Fine. Okay. So these are preliminary difference between primary and secondary HLH. I'm not going to go in depth about primary HLH unless you are preparing for an DM hemato-oncology. Primary HLH might not be so much important for an MD Pathology postgraduate. Secondary HLH, I need to know about the pathogenesis because that can be asked as a 5-mark question or whatever it is. Fine. Pathogenesis more or less the same. The mutation is the only thing which is different. Again, as I said, it might be more common for entrance exam, not required for an MD pathologist. Fine. Hello, Kajal. Okay. Go with the pathogenesis, whatever it may be, primary or secondary HLH. It's HLH, right? When I say it's HLH, it's overactivation of my macrophage system. That's all. When my macrophage is overactive, macrophage activation syndrome or HLH, some of them consider both as different disease, some of them consider as a similar disease, right? It's having overactivation of macrophages. That's the problem here, or my histiocytes, right? It's just overactivation of macrophage histiocytes. When I say an overactivation of macrophage histiocytes, macrophage is an antigen presenting cell. Yes, again going back to our basic pathology. When I have an antigen presenting cell, am I right in saying that this antigen presenting cell will activate one type of lymphocyte? Which lymphocyte it is? CD4 or CD8? Any day a macrophage when it's getting activated, it automatically will activate my CD4 T lymphocytes, right? This will activate CD4 T cells. Okay. As we already know, whatever may be the cause in HLH, my CD8 and natural killer cell function is going to be reduced due to mutation or due to the other way. So any case of HLH, I'm going to have reduced CD8 and my NK cell activity. It will be reduced, both primary and secondary HLH. When my macrophages are overactivating, it's activated macrophage. Activated macrophage does not phagocytose. They will secrete. What they will secrete is, they'll secrete interleukins. Right? They'll secrete interleukins. So when I have an active CD4, which is bound to my antigen presenting cells, what do you think will be the problem there? That also will do only one thing, will secrete more interleukins. Fine. Secretes interleukins. Okay. So with this interleukins, the primary function of all these cytokines and interleukins is to attract more and more inflammatory cell and make sure they produce more interleukins and make sure this like a cytokine storm, somewhat similar to COVID, right? Cytokine storm happens. So when they secrete more and more interleukins, one of the important interleukins is interleukin 2. Any one of you remember the function of this? Swapna, yeah, I would say it's for pathology residents. Fine. We'll discuss NEET sometime else. Fine. Okay. Interleukin 2, what will they do? They're going to go and activate my CD4 more, produce more and more lymphocytes, activate more and more cells. So this interleukin 2 will go and it'll go and bind to my WBCs. For that I need a receptor, right? So this will bind to my CD25. So CD25 is a receptor for interleukin. It's interleukin 2 receptor. So CD25 will be elevated. That will again trigger my CD4 cells. That will again cause an overactivation of macrophage. It's like a vicious cycle. That's all. So at the end of this, what I'm going to have is I'm going to have persistent inflammation, like a cytokine storm. I'm going to have a persistent inflammation. When I have a persistent inflammation, I'm going to have many outcomes of a persistent inflammation. Simplest outcome is fever. So almost every case of HLH will have fever, should have fever, right? So will a metabolic derangement, when I have an inflammation, will my metabolism be deranged? Yes. My lipoprotein lipase will be inhibited. That will increase my triglycerides. My acute phase reactants will be elevated. One of the common acute phase reactants is your ferritin. COVID taught us only one thing. Ferritin is an acute phase reactant, right? This will cause inhibition of lipoprotein lipase, LPL. I'm writing LPL for lipoprotein lipase. This causes increase in my triglycerides. And you'll have more of an acute phase reactant. All the acute phase reactants will be elevated. One thing which I'm going to concentrate here is serum ferritin. Fine. Perfect. Why I'm dealing all this pathogenesis, I do have a criteria. The criteria is dependent on all these pathogenesis only. Fine. Again, inflammation will do one more thing. It will increase my heme oxygenase. When heme oxygenase increases, it will act on my plasminogen activator, which will cause fibrinogen to become low. Fine. It will increase my heme oxygenase. Again, there's a little bit of hint of biochemistry here. My understanding is there will be low amount of fibrinogen. Okay. So this is what is going to happen due to the biochemical alteration in HLH. As I said, macrophages are overactivated. The primary function of every macrophages is going to eat everything. Pinakshi, ferritin is an acute phase reactant, right? So in any inflammation, ferritin will be elevated. That's an acute phase reactant. That's why in anemia of chronic disease also ferritin is elevated. In your COVID, ferritin was elevated. Whenever it is there, it will be elevated. Right? Okay. Another thing, one more thing is you will have hemophagocytosis. So when I say hemophagocytosis as a diagnostic criteria, I can see them in bone marrow, I can see them in lymph node, I can see them in liver, I can see them in spleen. any reticuloendothelial system. If I demonstrate hemophagocytosis, more than enough for me. As I said that, it's not a must for me to see hemophagocytosis. If I see, it's great, that's all. So this is my pathogenesis. If my bone marrow, it eats all my erythroid, myeloid and megakaryocytes, what do you think will happen to the RBC, WBC and platelet count? Will it reduce? It will reduce, right? That's what is going to happen. That will be the outcome for sure. So I will have cytopenias. I'm not calling it a pancytopenia. I'm just calling there is a possibility of having a cytopenia, right? So we'll go to the diagnostic criteria of HLH. Okay. So diagnose HLH, as I already said, there is both primary as well as secondary HLH. For primary HLH, I need mutations. If I see mutations, that's more than enough for me to diagnose primary HLH. I don't want any other criteria. If I see mutations, that's enough, right? So I divide criteria of diagnosis of HLH as A and B. So A is for my primary HLH. That's what your textbook, standard WHO textbook says. We'll go with that. So if you have molecular diagnosis, that's enough. Of any mutations consistent with HLH, that's enough. Okay, that's more than enough. I don't want anything else. Okay, yeah. If I don't have the molecular diagnostic technique present, or if you think it's an acquired HLH, that's also possible, right? It's also possible. Then I'm going to go with the second criteria. The second criteria is more famous. This is where you have 5 out of the 8. If 5 is present of the 8 criteria, I can diagnose it as a secondary HLH. As we already know, the one thing is my fever. Second, splenomegaly. That's why your clinical history becomes very important for me to diagnose HLH. Unless the question, the person gives you your fever, splenomegaly, I need biochemical levels also. If your hospital has your hospital information system, if everything is integrated, it's easy for me to retrieve the data. Otherwise, everything should be filled up in the form. Only when it's done, I'll be able to identify them, right? Third is my cytopenias. As you guys said, I might have pancytopenia, but that's not necessary for me. If you have more than 2 out of 3 lineage reduced, when you know when we call it cytopenia, right? Anytime it is like your normal anemia, normal leukopenia, normal platelet count reduction. Either 2 or even 3. I don't mind if it's 3. Fine. Fourth is the metabolic alteration, triglycerides or fibrinogen. Either increase in triglycerides or reduction in fibrinogen. Fine. Hypertriglyceridemia or hypofibrinogenemia. I'll tell you one important thing here. If you go with your textbooks, what you'll be written is you'll be given values for everything. Like triglycerides said that more than 265 milligram per deciliter. If you are going to practice as a pathologist, I don't want you to remember that. See, you are going to suspect your HLH. Definitely you'll have at least 5 minutes for you to give the diagnosis. Yes. Open the textbooks. Don't remember the value. That's less important for me. Remember CD markers. Remember IHC. That's more important. That will clinch me in the diagnosis. So just know that more triglycerides, enough. Less fibrinogen, enough. Don't want the values at all. You can any day open the textbook and write. Don't ask me what will I do in an exam. Don't worry. Write hypertriglyceridemia. I can write and give. None of your professors will know the triglyceride value. Unless the person is extremely textbookish, I don't think so any one of them will be. Fine. Fifth, like Meenakshi said that soluble CD25. Why CD25 will be elevated is interleukin 2 will come, that receptor is my CD25, right? That will be elevated my soluble CD25. Sixth, there will be reduced or absent NK cell activity. Fine. By reduced or absent NK cell activity, I am going to have a finding as well. Okay. 7, the acute phase reactor, right? They have an elevated ferritin levels. Okay. Ferritin alone, I'll tell you the value because ferritin is very important. Whenever I'm thinking overactivation, I have your 500 microgram per liter as a cutoff. This your professors will know. Fine. So do remember this. Especially after COVID, this has been given undue importance, so you have to know about this. Other values, I don't care about it. Fine. The last one, I'm going to write it as your hemophagocytosis. As I said that it can be in any organ, any reticuloendothelial system is enough for me. So as I said that I can have HLH with no hemophagocytosis also. Then I have 1, 2, 3, 4, 5. Is this enough to diagnose HLH? Do I need a biopsy at all? Actually, I don't want a biopsy, right? I can easily diagnose with clinical examination and blood investigation, enough. If any of these is not fitting into, let's assume I have fever, spleen is not palpable, cytopenias, hypertriglycemias, ferritin is elevated. I have only 4 criteria. Then they'll look for a biopsy. Then biopsy becomes very important. Again, when you're going to evaluate a bone marrow biopsy, look for all these. If I'm just giving you a hint where you have to spend more time, because time becomes very important when you consult. You can't keep a slide for half an hour, right? If you have a clinical suspicion of HLH, and if you see that 3 or 4 criteria are already present, search for hemophagocytosis. Search more diligently. If you see in the form and along with the values, 5 criteria are already present, write hemophagocytosis present. Who cares? Anyway, it is HLH. Treatment is going to be based on HLH only. If you see, there are no criteria for HLH. There are no criteria, or only 1 criteria is present, only fever present. The person is suspecting HLH. Impossible. Without cytopenias, HLH will never happen. So at least 3 or 4 criteria, I'm going to search more. 5 already present, it is HLH, irrespective of the hemophagocytosis. Don't care, right? HLH, which is considered HLH, that's all. This, no criteria or only 1 of 8 criteria present, it's unlikely to have a finding. Even if it is present, I cannot call it HLH. It could be an empiripolysis, right? So clinical information and the idea of the patient is very, very important for us to write a diagnosis. Because once you write a diagnosis, you cannot take it back. Remember that always in mind, fine? So these are about simple thing about your HLH classification, right? So to end with, I should have started this, told this first. We have a new histiocytosis classification. I won't say it's newer classification. It came in 2016. From 2016 onwards, I am not calling it as a benign histiocytosis or your malignant histiocytosis or non-neoplastic and neoplastic proliferation. Most of your standard textbooks gives you non-neoplastic, neoplastic only. The Histiocytic Society in 2016 changed the classification. Especially if you're writing a theory question, write this first. It looks impressive. The first group is called as an L group. L group stands for Langerhans. Your LCH, everything comes here. I'm not sure if you have heard about the disease. There's a disease called as Erdem-Chester disease. That also comes under this, right? LCH, if you remember, more than enough. Second group is called as an C group. C for cutaneous, which means your xanthomas, xanthelismas, or your cutaneous Rosard-Hoffmann, everything comes here, right? See, it's just cutaneous. Anything cutaneous involving histiocytes will come under this. But it should not be LCH. That's more important. Because LCH can also happen in cutaneous, right? It can also happen in skin. So it should be not LCH, any other histiocytic lesion. That's my L group. Third group is my R group. R stands for your RDD, Rosard-Hoffmann disease. Anywhere Rosard-Hoffmann, nodal, extranodal, everything comes under this. Sporadic, familial, there's familial Rosard-Hoffmann disease also. Everything is going to come under Rosard-Hoffmann disease. Fourth is my M group. That we'll see in the next class, which is malignant histiocytic lesions. Okay, which is malignant histiocytic lesions. And fifth one is my H group. H groups comes my HLH. Both your familial as well as your secondary HLH, right? Okay, yeah, these are your classical groups. Perfect. Good, Manpreet. Fine. So this gives an overall impression that you know the stuff. See, passing theory exam in any MD is easy. Pathology is definitely easy. Everything you can write the same inflammation, infection, neoplasia, healing, the entire thing, and you can fill pages. You start an exam with this histiocytic disorder, it will look impressive. Okay, this guy or girl knows much, so they'll not read much. And definitely in this LCH you will know, Rosard-Hoffmann you must have seen cases, you can build up easily. HLH you will know, and malignant and xanthoma, xanthelisma you must have known from your MBBS itself. You can easily write a 10-mark question or a 25-mark question, right? Doesn't matter. Microscopic differential diagnosis is what matters to us. Fine. Okay, that's about today's discussion about LCH. Let me know, do you want anything to change from the way of teaching? Because PG teaching, it's very vague. For the only reason, you must have understood by this time, entering into pathology is not easy, right? It has a very huge steep learning curve. It's difficult to memorize everything, and it's very, very vast. you should take a niche and you should go ahead with it. Until this month, we'll have random classes, and I have a WhatsApp group. You can take it from the Telegram group or my Instagram page. I'll share. Do join it. We'll just try to formulate a timetable for you so that we can go system wise. See, the advantage for me for teaching PG teaching is I will learn a lot. At the same time, you will also learn. Right? It's a mutual learning. When you see some cases, discuss it with it, right? Sure, Varun. We'll do it. Okay. Fine. Do let me know. We'll discuss about what can be done. Okay, you can download the Unacademy app. We'll do half of the case in YouTube and half of the discussion in Unacademy. Which is better for you, inside an app or in the YouTube? Because I just want your information so that we can do it accordingly. Okay, we'll learn a little bit more. Do give me feedbacks if you want to improve on some aspect of PG teaching which you think will help you. I'll definitely put forward. I do have a collection of lots of cases which has been done with the past 8 years. I will share them in the WhatsApp group. I am not so much comfortable with WhatsApp diagnosis, right? That's a bit difficult for me to do it. Okay, I'll definitely share you, but I'm not comfortable for WhatsApp. I'm not sure how good you are, right? Because it is for me it is difficult to diagnose on a WhatsApp. I don't know how you guys diagnose on a WhatsApp or Facebook or Twitter or whatever it is. I need a microscope and a slide for me to diagnose, right? We'll share it. I'll share the cases in the group. I want you to comment on whatever comes to your mind. We're just going to learn, right? No interference will be there. No professor of yours will come into the group, so we can tease the professors. We can do whatever we want. Fine. Okay. If there is any class in the app, I'll just put forward in the WhatsApp group. It'll be free as well. We can go to the Unacademy app and you can do it. Fine. Okay. Fine. Sure, man. Meenakshi will do it. Okay. We'll do it in both YouTube most of the time, and we can do it in Unacademy as well. Fine. Okay. Thank you for your time. See you soon. Till then, bye bye. Thank you.